The session is, again, a crossroad person. And this is the least we can say. She graduated and actually worked as a medical doctor. But she also studied sociology, psychology, and politics. She has hands-on experience in clinical ethics in the hospital in Zurich, but has also deep involvement in national and international reflection on ethics and medicine, evidence-based medicine, and health technology assessment. I hope she will challenge us on the ethical aspects of our work as a scientific advisory body. Professor Tanja KRONES.
Thank you. Thank you very much for inviting me to this exciting event. I really hope to have the chance to really bridge a little bit the gap, not also between ethics and science, but really to show that it is really an endeavor HTA is undertaking that is really a very important thing. It is no question that ethics is a part of HTA. In every definition you find in HTA, ethics is part of it. But is it an important part? We saw that a lot of HTAs never talk about ethics, and I hope to try to show you why that's the case. I start with a view, a very narrow view in a way, to say what is ethics about, and I say what is orthodox ethics, so a very normal ethical view. And I have two quotations for you, for very well-known philosophers both from Germany. Dieter Birnbach, a very nice guy, says that the common understanding of ethics is that it theoretically deals with the phenomena of morals and moral norms, as long as this does not touch the character of empirical theories. And Bernhard Gesang, well, a guy, nice guy, more or less, has one quotation. Sorry. Well, I'm a moral person. I value judgments, as you do. So there's one quotation from him saying, what does an ethicist do? Is an ethical ethicist a moral expert? He says that according to Hare, very well-known philosopher, the foundation of morals rests on the meaning of moral concepts and the knowledge of non-moral facts. Correct moral judgments are obtained when one is sure of the meaning of moral concepts and knows the facts. Exactly this is what an ethicist, beyond all doubts, is able to do in an excellent way. So don't HTA ask us, right? Good thing to do. Wait. But that's, of course, this one view ethicists or philosophers have on the normative sphere of what should be done, and that's the question, what should we do? And this kind of moral architecture goes as such. We have a messy, complex, normal facts and value situation, like this ours. We do an analysis, a crucial analysis of values, moral concepts, and perceptions, for a sound critique of all these parts of morality, of the moral considerations, to come to a construction of a fine house, a normative framework, that is ideally followed by implementation, a moral pragmatic. So that's the way the moral architecture goes of the orthodox ethics model. And just very, very shortly, two basic ethics perspectives which are very important from the ethics point of view, but also from the healthcare point of view. There are two basic ethical and theoretical perspectives that we have to know about. So, in ethics, or in health technology assessment, one perspective is that we should treat those collectively gaining most benefit utility. So it's the utilitarian principle. You have a budget, you have a limited resources, and you get a health gain out of it. And one prominent philosopher is Peter Singer. And when we know about that and we reflect on that, we use the knowledge we have to prioritize healthcare, to rationalize, and also to rationalize healthcare. That's one perspective. The other perspective is the Kantian perspective, the rights perspective, the deontological perspective based on human rights, saying that we have to treat those most in need of treatment, regardless of utility gain and final outcome. And that's two prominent philosophers, John Rawls and Immanuel Kant, you will see him after that, defending this perspective, that it's not the consequence that counts, but the human rights that is important. Well, that's for the ethics, and now for the science. And I have one quotation from a very very well-known social scientist, interestingly, defending a science view, and I will critique the science view afterwards. So one of the science view is that science today, Max Weber said in a quarrel on value judgment in science, and he defended a science. Science today, he says, is a vocation organized in special disciplines in the service of self-clarification and knowledge of interrelated facts. It is not the gift of grace of seers and prophets, dispensing sacred values and revelations, nor does it partake of the contemplation of sages and philosophers about the meaning of the universe. That's not what science is about. So you feel the quarrel already, don't you? Okay, and what social scientists say, that we see in these quotations, we see kind of boundary work. We do a boundary between very, very important spheres of our reality, between science and norms, between facts and values. We have a clear boundary. And from the philosophical point of view, it is the very important, and you should really know about it, the naturalistic fallacy that says that regardless of facts, facts are important, but what we should do is a sphere of freedom, and we cannot directly conclude from facts to what should be done. That is a naturalistic fallacy, a wrongness. It's not logically sound to do it that way. And behind it, there is a theory of science that is really a little bit old, that we have between the sphere of facts and the sphere of values. We have a clear boundary between the is and the ought, body and mind, from Descartes, that's the old dualism, from subjectivity, objectivity, bounded rationality and an unbounded one, society, science, lay view experts. We really have this clear boundary, says this theory. And you also find it, for example, in this publication, of a very nice publication of Tunis, where a nice colleague of mine alluded me to, two main components of a medical decision. And you see there how that thinking works. You have first the scientific judgment, the evidence you analyze, then you inform about outcomes, then comes in the value judgment, the assessment, then the appraisal, and then there is a decision. And you see that boundary also there. So you have the facts, right? The facts, then you have the values, and then comes the decision. Okay, I come back to that later. That is the theory of early modern thinking. So, second question is, what kind of ethical reasoning or approaches are implicitly or explicitly underlying orthodox, and I say orthodox, normal HTA procedures? What are the basic ethical principles of HTA? So the first one is that the focus is on consequences instead of the art of biomedical medicine. Consequentialism, therefore, and quite a positivistic understanding of science are implicit main theoretical strands. Positivistic means that you think that science is objective without any values. So that you can have evidence that is kind of having a truth in it. Very important. It is based, as we know, on published empirical evidence, published ones. We can't do anything else in HTA. And the ethical principle behind it, because we look at outcomes and aggregated outcomes and values of utilities, it is more or less a utilitarian approach, sometimes embedding in our measures societal patient's perspective in various methods, for example, quality, safe, and others. And the main outcome focuses on cost effectiveness, as we know, utility of new versus established technologies. And there are problems with it, of course. Problems we discuss also in HTA with evidence. We discuss also if what we do in HTA, and that's with the ethics behind it, is it really just what we do? And where's the autonomy of the patient and of the society and of practitioners in that? These are focuses that are discussed in HTA already, but the framework is as such, I think. And it's nicely, one of the pictures, one of the things I take out of it is the quality, because it's a very nice measure to allude where we have a gap and where we might be able to bridge. There was a very nice book, already quite old, in 1998, The Ethical Quality, a European project, and that was summarized as such. The economic principles referred to in HTA can be summarized as follows. Resources for producing health gains are scarce. Prioritizing is inevitable. prioritizing on the basis of explicit criteria is preferable to prioritizing without, and maximizing the health gain from available resources, e.g. by equality, is a good criterion, which does not imply that it is the only one, says Edgar et al. So that's the description of equality. And if you kind of analyze it from the viewpoint, what is equality? Of course, we know it's an aggregate lifespan, an average one, multiplied by an aggregate standardized quality of life by different groups. It depends on which quality of life measure you take, of a state of health or a specific measure, and according to that also about a patient population having that state, of course, to evaluate measures and costs to inform decision, healthcare financing and implementation. That's what it is about. And a very, very ethically important thing is to understand that the quality is used against opportunity costs, and the problem, it hints at opportunity costs, and it is against the rule of rescue, which is the Kantian perspective on the problem. And I will give you an example. This is a very highly discussed issue, the morbus pompe and myosim, one orphan drug that is very, very expensive and that helps very few people, but is really enormously expensive. And that's what the newspaper, this is one of the newspapers from the UK, miracle drug brings Todd back from the dead, which is myosim, morbus pompe. And there was a recent discussion in Switzerland for adult morbus pompe patients, and the highest court denied morbus pompe patient a treatment for myosim, and that was the discussion about this, that the health insurances leave this pompe patient to his own, that they don't touch him, that they are irrespective of his problems. That's how it is discussed in the newspapers. And behind that, how these pictures are seen, these faces are seen, is the rule of rescue, which is a very important perspective, I think, also for doctors. Described by Johnson first as the powerful human proclivity to rescue a single identified endangered life, regardless of cost, at the expense of any nameless faces you don't see, who will therefore be denied healthcare. That's the opportunity cost problem, right? But still you have this single patient there. And that is what is kind of the core behind it. And of course, you know all these cost per quality situations and the cost per quality gambles. And if you look at myosim, there are different calculations, but it's about 500,000 cost per quality for an adult morbus pompe patient to pay. So it's really, really enormous sum, of course. And everybody of you knows that the thresholds are much lower in those countries which set thresholds for willingness to pay. Well, okay, one could say, well, is that the case? Okay, it's clear we have to have this recognition. Qualities are important because we have the opportunity costs. But the question philosophers also ask then is that if our qualities are really sound, if they account for rights. And the rights perspective is as important as the other perspective, as I told you from the theoretical point of view. And I just brought you one, you know the discussion very well, I just brought you one illustrative example of the problem of quality of life and happiness. A very early study, Brickman et al. They looked for lottery winners and accident victims and had a measure of happiness, a very quite sound measure of happiness. And you can imagine that at the event of a lottery win, they were quite happy, the lottery winners, and the accident victims who had a policy were quite unhappy. But imagine what was 1 year after. You can guess maybe what happened. There was no difference anymore. So after 1 year, there was the same happiness in those two groups. And the title was of this was Lottery Winners and Accident Victims, Is Happiness Relative? And that's one of the problems, of course, we have when we measure quality of life. And of course, another just quick critique from the philosophical rights perspective is that, of course, inherent in the quality are problems. For example, that in the logic of the quality, when you save a newborn with slight disabilities, you have a less quality gain because you have less quality of life than a healthy newborn has when she or he is born. And of course, the UN protection of the rights of persons with disabilities says we cannot use that as a discrimination feature of people with disabilities, right? And one very strong, very nice, very smart philosopher, Weimar Lübbe, concluded, she's very much in the discussion of healthcare, concluded on her critique on qualities, I for one have argued that resource allocation should satisfy claims, not maximize value. One advice I like to give to healthcare decision makers when I'm asked, but the only one of course, but an important one in my view, is that whenever experts begin to talk to you about better outcomes, ask back, better for whom please? And if the answer is better for society, or even, which can happen if the expert is a philosopher, better for the universe, ask back again, who exactly is that please? So she's heavily criticizing this quality perspective. So you see that there's a heavy discussion between these two basic views on what is a good way of healthcare. Okay, and within that, there is a mismatch that is very important to understand and to bridge the gap, and that's the second part of my talk. So we have a mismatch between philosophy and HTA philosophy, I think. We have a mainstream bioethics perspective that says, with a naturalistic fallacy paradigm, we can prescribe what is morally good or right only from the normative viewpoint, from theory, right? Prescriptions are only valid on the basis of good philosophical reasoning, and are in philosophy, as you know, bioethics and bioethical experts are really increasing on their impact in philosophy and also in politics, right? They have a huge impact now. On the other hand, you have HTA philosophy, which is based on the best available evidence, which must involve politicians, for example. The main focus is, if we have one on justice, and from the perspective of HTA, recommendation is only valid on empirical findings, especially economic utility arguments, and it's also increasing, right, on the impact on policy making, right? That's the mismatch we have when we talk about ethics and HTA. And now I try to solve it. So I think one thing we have to know, of course, is that we have to consider all aspects on a policy level. We have to consider important rights, norms, and principles guiding the individual situation and implementation of guidelines. And the question there is the norm justifiable or relevant, or not justifiable or relevant? And we have the sphere of consequences for individual patients, more good than harm or harm than good for an individual. And we have the consequences for the healthcare system, more harm than good, more good than harm, right? And all of these aspects are, of course, important in the political debate. And they can conflict. That's what an ethical dilemma is about. If you look at one sphere, it may be that you violate another sphere, right? If you only look on the consequences of the healthcare system, you really might violate certain rights, and vice versa. That is what we have to talk about and to be transparent of. Well, and now I come to the problem of the first theory of science I try to quickly demonstrate to you. In every serious theory of science, we don't have that gap anymore. And we have a physicist, a physics person here, especially in physics, which was the strongest science, yeah? They criticize that there is a real viewpoint on objectivity. There is no viewpoint on objectivity anymore in physics. But it's defended in ethics, and it's also sometimes defended in HTA, that we have the objective truth. So we know that this early modern gap, the early modern border between science and society is and art is really vanishing. We can't defend it anymore on theoretical and empirical findings. And well, this is the most important quote and take-home message I know from every talk. At least just only one sentence is remembered. This is the one that I think for me is most important. A quote by Fulford, who is a psychologist in England. Value judgments are indispensable to scientific practices, such as defining research questions, making assumptions, setting significant thresholds, or balancing between the advantages and disadvantages of different methodologies. Scientific knowledge cannot be value-free, but this does not make it any less scientific. We have to think about it and be self-reflective and know about that. We do this value judgment. We can't prevent ourselves from making value judgment. This is good science in his view and also my one. So, you might know this one. This is one of the very important papers on HTA from the Working Group 4 on best practice. And there you see the whole process of HTA standardized in one paper. And you see the whole process of assessment and appraisal. And you find ethics, psychology, and social science, but what we all talked about was three. In this part, after definition of research problems, after all that came in, you have a single part of psychology, social, ethical sources of data, right? And then maybe you find it in the report. So one report on ethics maybe, or on social consequences and stuff. But if you take that seriously, what I said before, it's really that ethics is of course also in other parts, right? Which question is asked, who, by whom, for example? Which thresholds do we take in the analysis? And all of these parts are value judgment, and we have to think about them. And also, I think we need another form of ethics, and the orthodox ethics I showed to you is of course not the only view on ethics that is defended in the world of ethics, and we have a fierce struggle at the moment going on in the sphere of ethics. Another viewpoint on ethics is that critical bioethics, as it is called by Alan Hedgecoe, requires bioethicists to root their inquiries in empirical research, to challenge theories, use the evidence, to be reflexive and to be skeptical about the claims of other bioethicists, scientists, and clinicians. The aim is to produce a rigorous analysis of lived moral experience. And if you look at that from the HTA point of view, I think it's important to use ethical theories in this view as practices, as heuristics, to know about them and to use them in mind, to operationalize them into practice rules, instruments. I will show you one example at the end. And to use that in a way that really tries to raise the validity of what we describe in an HTA. So to raise the cultural effectiveness, because ethical reflection are very, very important in implementation of results. So I think that when we look at the whole sphere of society, which is a very well-known concept of describing the sociology and society, you have a macro level where HTA is situated, where the focus is on distributive justice, of course. You have the meso level of clinical practice guidelines, where the focus is on procedural justice. You have to see that every stakeholder is there. And you have the micro level of evidence-based medicine for the individual patient, very much looking to autonomy. I think you have to involve, really, because it is important to see the public in every part of it, and you have to use an ethics concept that is context sensitive in the way that I quickly alluded to, that you use your evidence for that, and you challenge the theories, and sometimes also criticize the norms that are part of society. And one very important thing is, when we do that process, that we really show where the value judgments are in our analysis, and to really get the patient and the public into the analysis. And one movement, worldwide movement, is that we more and more use decision aids of patient clinical practice guidelines, patient-oriented guidelines, except from only expert or evidence-driven guidelines and processes. And I give you a very nice example before I first allude to one thing. When we do an HTA, right, we normally learn to use it that we have a lifespan, we have the efficiency, we have a quality of life in treatment 1 or 2. Then we have a cost per quality when we use that measure, and then we have a treatment reimbursed or not, right? But in that box there is somebody. There is a computer model, but there is a human being in it. And there were decisions, for example, like how we look at the evidence, what is the validity of the studies, do we discount values that in the future, or do we count them yet now? So there are a lot of value judgment made by humans in these models, right? But it's in the black box normally, you don't see it after that. And a very nice endeavor was undertaken, another Dutch guy, Bert Mollewijk, a very nice colleague, also an interdisciplinary colleague, who researched decisions about aortic aneurysms, and to raise the values or the understanding of how to best decide on these aneurysms. And the first thing that he found was that when he looked at surgeons talking about if there should be an operation, you might know that the only threshold that is used normally is the diameter of the aneurysm. It's 5 centimeters, and if it's higher, surgery should be done if it could be done, right? And if the surgeons use the word time bomb, you have a time bomb in your stomach, and they use it, 100% of patients will be operated. The patient decides on operation. So if you frame it that way, they do it, right? And he tried to make it better, to really have a decision analysis on that, to say, see, from the evidence base you have 3 perspectives. You have wait and see, like in the prostate situation, right? You have surgery, wait and see, and doing nothing. And for every of these situations, you can really count what is the consequence for that. And that he used not only in the process of HTA in this view for patients to make them understand what's happening, what the decision is about. And there was a very nice brochure that was given to the patients because the model makes a recommendation. And in the model, there was a brochure for patients saying that for patients, the decisional analytic model advises the best treatment by taking into account 3 factors: a maximal life expectancy, expected life years in the future are valued less highly, discounting, because empirical studies have shown that patients discount life expectancy. In case you value the future years differently, please contact your surgeon. And as good as possible, quality of life. Quality of life refers to patients' average assessments, e.g. utility of a certain health condition. For example, the model takes into account the average quality of life utilities of having an aneurysm and the health condition after an acute aneurysm surgery. Therefore, the expected life years of the various health states associated with the different treatments are corrected, decreased. There is a chance that you assess your actual and the hypothetical life conditions differently. Please realize that the model's recommendation is just an advice, not a mandate. Please take into account that other factors might be relevant for the final treatment decision. The model's recommendation is only based on a limited amount of factors. This might imply that you choose to neglect the model's recommendation with or without consulting a surgeon. The information from the model is just a tool in the consultation between you and your surgeon. And you might imagine that I have a last example for HTA of that. How many minutes do I have left?
10 minutes.
Yeah? Oh, great. So I can give you the other example of a decision aid, and I'm not quite sure if you're aware of this movement of decision aids. Decision aids are really an evidence-based tool to make the values implicit and not like the analytic decision analysis tool makes a recommendation but shows the values and let the patient decide, right? And one very good example of the problem of a gap is buffering for atrial fibrillation. We know since about 25 years that patients with atrial fibrillation have 5 times higher risk for stroke in the next 5 years. We also know that anticoagulation entails a relative risk reduction, while in absolute, you know, is a different one, of at least 68%, but only 15 to 44 patients with a clear indication and no contraindication take the tablets. So is it that patients are irrational? Is it that physicians are irrational? I think it's not the case. There are reasons. Physicians have own heuristics. And there's one article I would really strongly recommend to you, this article we discussed just before, collectively constructed mind lines instead of evidence-based guidelines. Because clinicians use their practice and they are afraid, for example, of bleeding. And they think that frail people, when they have the risk of falling, that they evaluate it differently, right? There are some barriers in the healthcare system for doing anticoagulation, of course. For example, the blood sample taking, we know that, and we know that there are new drugs that we think may circumvent it. I'm not quite sure if the evidence is that strong. I don't think so. But of course, patients might have different priorities. They might, and that is very, very typical for patients, they may have a fear of bleeding, an acute risk that is hitting me now compared to that you have a risk reduction in the future. And that's a very, very human risk behavior, that we are very afraid of acute risk, like operation also, that we have to take now. And we recommend often evidence-based measures that reduce the risk in the future. And that's, of course, an evaluation that not every patient has, right? And that's might not be important to a patient. And when you use the best evidence and put that into a decision aid, and these are typical decision aids that are used, and there is a big, huge inventory on evidence-based decision aids used by the Ottawa Health Research Institute. You can look at them. We know that patients should know about absolute risk and absolute risk reduction, and you can show them by 100 smileys like that, and you can show what warfarin does, also what aspirin does, and what it means if you don't take any anticoagulation drug for your stroke. And you see, as you know, if you're an evidence-based medicine, that the absolute risk reduction is not that impressive when you use warfarin. So it's 1 to 2 to 3, depends on the absolute risk we have, right? And if patients are best well-informed, you see the bag there, you said, what is your value? Is it more important to prevent a bleeding, or is it really important for you to reduce your 10-year risk of a stroke? That's the value behind it. And if patients know about it, they choose even less warfarin and more aspirin, less effect, but less side effect. That's the decisions patients take when they are well informed. That's the evidence-based decision when you take the values of patients into account. Okay, last part of it, very small. And what kind of methodologies are, to my mind, suitable to find, integrate, and generate really ethical consideration of a technology? Ethics seems to be really a lot of stories, and I also told you some stories. But in HTA, we have a narrow time, and we have to have really recommendation and really a clear way of structuring what we know about ethics also in the process. And I give you one little example. You will find it in the slides when you look at the website. I don't go into it. I just give you the example so you can look it up. We had the example in the IQWiC, the German IQWiC, which is comparable to the KCE, of high-dose chemotherapy with autologous stem cell transplantation in female breast cancer. And the setting is the IQWiC in Germany, which was established by law in 2004, almost the same time as the KCE was founded, right? It receives its commissions to perform an HTA directly by the Federal Joint Committee. It's a statute where there are statutory health insurance, healthcare providers and patients without the right to vote, by the way. Still, patients are in there but don't have the right to vote. And they give recommendations to the Federal Joint Committee who decides on coverage. So the IQWiC has, I think, small influence on priority setting and on final decisions, a high responsibility for delivering the evidence to the decision-making committee, and there is a high public awareness of recommendations by the IQWiC, also like the NICE, and I'm quite sure about the KCE itself. And we really thought of, how to really integrate ethics into HTA, and we choose this project as a piloting, and it's now done consecutively. So there is the INATA Ethics Working Group of the International Society for Health Technology Assessments, and we alluded on the methodology of what can we use for the ethical theories that are fit the HTA process. And we chose the Socratic approach, that's him, to ask the right questions, right? To ask questions and to try to find the evidence for these moral questions important for the health technology that is under assessment. And there are some realms where the questions are about. There are moral issues, for example, about the proportionality, benefit-burden ratio, societal values that are important. There are questions with respect to stakeholders, benefit for whom, like Weimar Lubbe said, who benefits? So the patients, the customers, who is benefiting? Questions related to technology. What is the symbolic value, the ethical implication of this technology? We heard about the cochlear implants, which is a very highly valued technology, and I think this is a question where this part is very important. What is the symbolic value of it? That we don't have deaf people anymore and no language of deaf people anymore, for example. We have moral aspects of methodological choices, which endpoints we take, which thresholds we choose, which quality criteria we include. And we have also questions related to technology assessment. For example, who decided on the assessment and why? And why did we choose this question and not the other one? And what is the interest of the HTA community to examine this technology and not the other one? Why is there so much impact of pharmaceutical drug technology assessment, not so much on complex interventions? I mean, it changes now, right? But that's the way we discuss it. So we had an ongoing HTA on facts, the facts. We had startup meetings with an ethics group with the HTA guys. We used the questions, defined inclusion and exclusion criteria, and did a systematic review and a reflection on the ethics part of this methodology. And we systematized the results we got from this view by the questions, and that's published in 2012. So we really found potentially relevant documents, a lot of them. We identified them. It was a long process of doing it, and there were 34 potentially relevant documents identified and assessed. And we have found high quality information on obvious and non-obvious ethical aspects in this screening process. And you can look it up in the literature. Just I have to get because I want to switch to the last slide. Sorry for that. Is there a, there it is. Right. So, is it easier with ethics? And of course, we have to prioritize an HTA, and this is a high time-consuming situation. We found that it is definitely more time-consuming. You need more personal resources, you need specific abilities, you need expertise in HTA and also ethics. You need specific screening criteria, you need another way of screening, another model of screening to summarize the systematic value. And to have knowledge in qualitative analysis, because you use also arguments. You have to structure arguments, what you get from the literature. It's not quite easy. You really have to, we really struggled with that. We have to question the impact of ethical aspects compared to the facts in the political process. So how is it summarized? We struggled with that too. But we think that when we use really the ethics in the HTA process, the whole HTA process, we think that it leads to really relevant knowledge for patient and healthcare systems. We can deliver from the HTA community additional decisional criteria, especially in situations where the evidence is not clear, contradictory, or obviously biased, that was the case in this situation, by external factors. And we hope that the certainty of appraisal to the authorities is increasing, or I think it is increasing, because we deliver the facts that are also relevant. So, proposal, let's construct a concomitant brochure for HTA reports to decision makers. Please take into account that other factors might be relevant for the final decision on the health technology. The model's recommendation is only based on a limited amount of factors. This might imply that you choose to neglect the model's recommendation with or without consulting your experts. The information from the model is just a tool in the decision together with public and affected patients. Thank you very much.